All right. Well, thanks everybody for joining us this afternoon. I want to welcome everyone to today's webinar. I'm Rob Saunders. I'm the Senior Research Director for Healthcare Transformation here at the Margolis Institute for Health Policy at Duke University. And today's webinar is talking about the future of accountable care, or how we can take what are currently alternative payment models and make those into the norm. I'm going to share some of what we've learned about accountable care over the last decade or so, and then talk about its implications for the future, and then dive deeper into each of those lessons with a great panel of experts. I want to recognize and thank West Health, who's our collaborative partner in this work. This webinar is part of a broader collaboration between the Duke Margolis Institute and West Health to accelerate accountable care in the U.S. healthcare system. And I want to introduce Namrata Uberoy, the Director of Policy at the West Health Policy Center, who's joined us to help set the stage. So Namrata.
Thanks, Rob, and thank you to the Duke Margolis Institute for your partnership and our collaborative work to advance value-based payment reform. We here at West Health continue to be committed to efforts that lower healthcare costs, as well as ensure successful aging and affordable healthcare for all Americans. And we are very much looking forward to continuing our work with Duke Margolis and experts like today's panelists to continue to accelerate progress today.
Yeah, and so I want to help set the stage for today's discussion. First, I need to acknowledge, we're in a period of change in the health policy environment. However, accountable care has had long-term bipartisan support, and there's often common elements of accountable care between different administrations. However, accountable care faces some headwinds and some tailwinds on the public and the private sector side, and so part of the goal of today's conversation is to figure out where there's some opportunities to improve and to accelerate its use, recognizing that sort of broader market trends and broader trends in health policy. And so during these periods of change, it's helpful to take stock of what we've learned, see where there's opportunities to improvement. And Namrata, maybe I want to start with you a little bit here in identifying some of those opportunities we may want to explore today.
Absolutely. I mean, I think there are a lot of opportunities out there. And as our teams here at West Health have been working with clinicians and health systems on the front lines as part of our learning and action networks, we're constantly hearing the need for harmonization and simplification of the many overlapping and complex payment models. And, a lot of this and the burden is really currently being shouldered by our healthcare workforce. Our networks have also shown incredible innovation in areas like geriatric emergency departments. And when these GEDs are partnering with what is typically considered really uncommon bedfellows of accountable care organizations, what we've seen are real opportunities to better serve older adults, lower healthcare costs, but also help solve kind of overcrowding and boarding issues that often face, many of these systems. But really, to scale these innovations, we're going to need supportive policies and payment approaches.
And I think that scale is an important point here, Namrata, and that you need policies, you need different types of payment approaches if you really want to see things scale beyond the heroic impact, efforts of folks in an individual healthcare system. But there's a number of complexities that you need to solve to help with that scaling. And I think we're going to talk on some of those in today's webinar, like ensuring benchmarks provide sustainable goals for improvement, aligning and focusing quality measures on the important areas for improvement, and reforming risk adjustment so that it's accurately and as objectively as possible reflecting the actual population needs. And there's broader strategic issues that have bedeviled accountable care, like engaging specialists, which haven't been as deeply engaged in accountable care to date, or supporting multi-payer alignment, given that you want to focus attention on common goals while reducing some of the administrative burden.
No, absolutely. And I think we can all agree there are a lot of, solutions, or looking at a lot of solutions for these kind of very thorny technical challenges, but I really want to emphasize kind of also the importance to draw on what we're seeing for the front lines of care. For instance, in our learning collaboratives, we've identified where policies might not really meet the goals, right? Because of practical challenges on the ground. There's lack of data, lack of timely data, or there are also challenges in implementing a new approach in the existing care workflows. And one thing I think that is exciting and really is an opportunity to highlight is the real potential for rapid learning, right? Where one doesn't need to reinvent the wheel, it can leverage peer networks, and then we can take those learnings and really further translate them into more effective policy. I'd say overall here at West, I think we're really seeing the need for better care models, corresponding policies that address this quality and cost of healthcare for older adults. And then I think all the work we're doing here really shines a light on the kind of need and urgency to address that with smart public policy.
Thanks, Nimrata. I echo that and look forward to continuing to work with you and the West Health team and building on that, our current work. And with that, I'm going to turn things over to my colleague, Rachel Bonesteel, who's a senior policy analyst here at Duke Margolis, who's going to summarize what we've learned in our research to date and can help frame our panel discussion. So, Rachel?
Yeah, good afternoon, everyone, and thank you, Rob and Nimrata, for providing that level-setting context ahead of this discussion. In that same vein, I wanted to spend a few minutes teeing up some key themes for our panel in the context of the current accountable care landscape. First, I want to echo Rob's thank you to Nimrata and the West Health team. As Rob and Nimrata both mentioned, the policy landscape is changing rapidly, and we appreciate our collaborative partnership to advance and accelerate value-based payment reform in the U.S. healthcare system. To further set the stage for today's panel, I wanted to highlight several overarching trends in accountable care that will likely inform future policy decisions. Accountable care has had long-term bipartisan support to align healthcare payments and benefits with care that improves quality, access, and affordability. And over the past decade, accountable care uptake has increased, including through the launch and continued implementation of the Medicare Shared Savings Program, innovation center pilots, such as ACO REACH, and commercial insurer efforts to design and implement accountable programs. CMS recently announced that, as of January 2025, over half of traditional Medicare beneficiaries are in accountable care relationships. And according to the most recent data available, across all payers, participation has increased to almost 30% as of 2023. Key learnings from model implementation, including through the Innovation Center, have been generated, and promising interventions have been scaled in the core chassis, such as the Shared Savings Program. However, as we look to the future, accountable care is at an inflection point, more prevalent than ever, but still considered an alternative to fee-for-service. Today, panelists will discuss potential opportunities to make accountable care the norm and strategies to build on key learnings from efforts to date. And we wanted to acknowledge different payers are impacted by various issues and policy decisions under consideration. Here we outline some of these issues to create a fuller picture of the current landscape. Common issues across payers include risk adjustment and benchmarking reform, performance measurement alignment, primary and specialty integration and engagement, and data modernization efforts, to name a few. At the same time, acknowledging there are nuanced challenges across payers, there is also an opportunity to support multi-payer alignment across key policy areas to help reduce complexity and administrative burden for implementation and limit variation in requirements for performance measurement and other design features, as programs across payers may use similar measures and therefore can devote fewer resources to collection and reporting efforts. Alignment will also be important as the predominant source of coverage in Medicare and Medicaid is now through private plans, which use the same claims infrastructure for fee-for-service, but currently differ in measures, data, and other technical details for accountable care. So as I previously mentioned, accountable care is at an inflection point. The current landscape includes not just the trends toward increasing adoption, growth in Medicare Advantage, and opportunities to learn from model and program implementation. It's also important to recognize the broader headwinds to adoption that Rob mentioned earlier, including upfront costs, especially for smaller or rural practices, provider capacity challenges, and the administrative burden of implementing programs with different requirements across payers. So in recognition of this dynamic landscape and broader system challenges, Duke Margolis and West Health have been engaging with healthcare leaders and experts to outline a potential path forward for accountable care, including the identification of key policy areas or themes to speed progress and increase impact, reflecting on lessons learned from past experiences. Additional details can be found in a Health Affairs Forefront piece that we published in January, and we have provided an overview of key themes here. These include simplicity in model design and implementation, which involves advancing care reforms that are more straightforward and administratively simpler across payers, and supporting payment and benefit designs that enable accountability for total costs and outcomes that matter with clear goals. This can involve efforts to identify best practices and innovation center models informed by key learnings that can be scaled into the broader Medicare program and be leveraged across payers. Opportunities to promote transparency can include providing clear, available information on quality or outcomes and costs for confident decisions and valid comparisons. This can include increasing data availability to clinicians and patients to support more informed care decisions, including timely and accurate data for providers to effectively intervene for a patient facing avoidable health risks, make an informed referral to a specialist, or identify and address medication authorizations. So when it comes to explainability and effective communication, accountable care or value-based care means different things to different people, with the term oftentimes not resonating with patients. Long-term investments in accountable care can be supported through clear communications about how efforts improve patient care and support clinicians on the front lines to encourage participation. Leveraging the flexibility of accountable care payment for services that promote whole person care, chronic disease management, and the provision of preventive care can improve access for coordinated primary and specialty care and non-medical steps to improve health. And finally, it will be critical to advance policies that support sustainability, including support for state and regionally led efforts that enable system-wide reforms to address community priorities, and also recognizing the need to support continued and new participation, including support for rural safety net and smaller practices in accountable care. And with that, I want to turn things over to my colleague Frank McStay, Assistant Research Director for Medicare Accountable Care Transformation, to introduce our panelists and tee up a discussion about these key policy areas and opportunities to advance accountable care. Frank?
Great. Thank you, everyone, for joining us today. Thanks, Rob and Namrata, for giving us some guardrails for the conversation today and kind of teeing up what we're going to be talking about. And thanks, West Health, for your longstanding collaboration and support of advancing accountable care, things we all care very, very much about on this call today. And thank you, Rachel, for teeing up and doing such a great job of providing some additional structure and a roadmap for some of the comments we're going to be making today. Again, like recognizing we are in a time of change, there's a lot of work that there's bipartisanship for. And so hopefully we're going to talk about some of those areas and some of those opportunities, trying to keep it very solution focused. To that end, I'm really happy to introduce our esteemed panelists. So first on my list is Kevin Larson, Senior Vice President for Clinical Innovation at the Center for Advanced Clinical Solutions at Optum, who has also served in a variety of senior roles at CMS and ONC from 2012 to 2020, including as HHS's Senior Health IT Advisor. Natalie Davis, CEO of United States of Care, who also worked at CMS from 2010 to 2016, and previously was Strategic Director at the Bipartisan Policy Center, working along former Senators Bill Frist and Tom Daschle. And then finally, Purva Rawal, former Chief Strategy Officer at CMS, at the CMMI Innovation Center, and previously on faculty at Georgetown, and spent a lot of time in healthcare consulting and on the Hill. I think what we really wanted to kick off today, recognizing the key themes that Rachel kind of teed up for us and providing a roadmap for a conversation. And as Rob said, really taking stock of what we've learned and reflecting on kind of what those opportunities are. Would love to hear from you what's necessarily top of mind in the context of those key themes, and what are those current gaps or barriers, and how do we make progress in terms of those themes and making alternative payment models the norm, with the ultimate goal of, again, improving care, lowering cost of care, and improving population health outcomes. Kevin, maybe I turn for you first for some reflections there.
Sure. We've been at this a while now, which is great. And one of the reflections that I've had that I didn't see on there is I remember in the early days, in the early 2000s, moving to value-based care, and one of my colleagues at a health system said, the problem is we can't predict the risk. When we're in fee-for-service, I can predict the risk. I can know what to invest in. I know what to do. And predicting that risk as a health system is really hard when you don't know what's going to happen with the policy, when you don't know how many payers are going to offer a value-based care model. And so even when we wanted to, it was hard to do without a sort of clear path and a clear understanding of what's ahead. I first got to know Rob back when we were working on quality measure alignment more than 10 years ago. This has been a priority for multiple administrations. There's a lot of work going into it. The way we thought about that alignment is that it needed to be more than just a technical alignment. You actually needed to align things like the timelines and the methods of data collection and the programs around this, that some of the chaos comes not, everyone will point to the same measure and say, well, we all are using that same measure. And then you look under the covers and they've tweaked it, or they've put it on a fiscal calendar instead of on the actual calendar, or that they'll do something that for a health system becomes super hard to manage. And so we need continued focus. I know CMS has been focusing there on their digital quality measurement program and alignment, working closely with HEDIS and the Joint Commission on that alignment, but we need more work there and more work to automate those measures, so there's not so much time and energy spent to just make the measurement infrastructure work, but actually time to reflect on the measures and use them for action.
Thanks, Kevin. Natalie, what's top of mind for you when we think about those key themes?
Yeah, thank you so much for bringing this together. It's a really important conversation, especially right now. You know, at United States of Care, we build all of our work on going out and talking to people across the country to find commonalities across demographics and make sure we're building a more fair healthcare system. And as we set out to explore the kind of changes that people want in the healthcare system and where their frustrations are, we know that so much of it is rooted in our fee-for-service approach and how we pay for healthcare. People, of course, don't use the word fee-for-service, but one woman described it as a high school cafeteria line where you get healthcare slapped on your tray and then you have to move down and someone else slaps healthcare on. And we thought, what a great analogy for fee for service. But we hear often, it's no surprise, that healthcare is just so expensive for people. They feel like their doctors and providers aren't talking to each other. They feel like they're navigating this maze of a healthcare system alone, that they're not being seen as a whole human with lots of different healthcare needs that are often interrelated. And that they're really just seen as a collection of problems and not a full person. And so it really begs the question, if this is how patients feel like the healthcare system is treating them, why isn't there a more robust shift into patients demanding something like outcomes-based care, value-based care, even if they don't use those words, of course. So we really went out to see what would resonate with people across the country as we think about the promise of paying and delivering healthcare differently. And I'll share more about it over the webinar, but there are a lot of tenets that really resonate with people. If we put it in their perspective. For a decade over, we've talked about it in terms of, payments and incentives and people being placed into models and attribution and risk adjustment. And that doesn't actually resonate with people, and it doesn't resonate with the policymakers that we need to make sure this stays a bipartisan kind of effort into healthcare. And so, what really resonated with people is the idea that in this new way of giving healthcare delivery, that they are seen as a full person, that their elbow pain and their back pain might be connected to their diabetes and their mental health. So this idea that they're seen as one. The idea that they have more time with their doctor, time was so important to people as they thought about what would benefit them the most from doing healthcare differently. And this idea of care coordination and having people help them move through the system, their data would move with them, that doctors would talk to each other and they wouldn't have to be the in-between. And I know we'll talk a little bit more about it, but what they absolutely hate is the idea of the word value. It makes them think of bargain brands. One woman said she doesn't buy value brand bacon, and so she doesn't want value brand healthcare. And so it really turns people off. And that's not just about lipstick on a pig. It really is the idea of, can we make this people-centered and make sure that we're moving it forward? So what we hear from our listening work is really clear. People want a different way for healthcare to be delivered. They really want to be at the center of it. And we know that, patient first sort of care models that are being explored and, tweaking old ones really can help put patients at the center if we focus on it. So that is always top of mind for us at United States of Care.
Thanks. Purva, what's top of mind for you when you think about those themes?
Well, first I'll just say thanks for the chance to join you all today, and a big thank you to the Margolis Institute and West Health for the thought leadership in the space, especially at a time where I think, as everyone acknowledged at the top, there's a lot of uncertainty. It's great to have these conversations where we can surface hopefully many of the opportunities that still lie ahead. What's top of mind? So as Rachel said, we have over 50%, over half of Medicare, of beneficiaries in traditional Medicare in these accountable longitudinal care relationships at the start of this year. And as Natalie said, our hope is that these accountable care relationships are really, we're developing models and care programs where people are seen as a whole person in the way that Natalie described, right? And that all of their needs are being assessed and their care is being coordinated. CMS had set that goal in 2021, and I think we've seen some steady progress made, especially with the Innovation Center and the Center for Medicare at CMS working together. That goal, honestly, was set. Kevin said, we've been on this journey for a long time, and that is absolutely true. This is, crossed administrations and multiple transitions at this point. And CMS set that goal in 2021 after reviewing, lessons learned from a first decade of testing not only Innovation Center models, but learnings from the Permanent Shared Savings Program and discussions with a wide range of experts on what the next steps were to really transform our health system into the one that Natalie described, one that is more people-centered. That really helped, I think, galvanize this accountable care movement. When that goal was set, we saw the healthcare industry embrace this concept and goal, and so much learning has happened on the ground just even in the last 3 or 4 years. And thanks to the research, I think, that has been done by US of Care and others in the space, we know that people, and I'm using the term value, not in value-based care, but they actually value long-term primary care, mostly primary care-based relationships with providers that are working for their health and in efficient ways, right? And along the way, I think one thing that's really top of mind for me is using this feedback continually to shape what accountable care looks like moving forward, so that we know as we're testing new models or new approaches that we're actually testing them to meet people's needs. But we have a way to go. We have over half of beneficiaries in Medicare in these relationships that hopefully address their needs holistically. But we have many millions of Americans that are served by other payers in Medicaid, commercial insurance, Medicare Advantage. I know Kevin can speak to some of the challenges and opportunities there as well. I know we're going to touch on hopefully some of the issues today that are top of mind for many of us in terms of both challenges and opportunities around data sharing and interoperability. We really want to be able to deliver whole person care across primary and specialty settings. We want to be able to use data and interoperability to assess people's and address their health-related social needs, which we know are critical to achieve better outcomes. And then honestly supporting people in navigating what's a really complex health system right now. And hopefully accountable care helps us do that too. And then just really briefly to go back to some of the themes you noted in your question and that Rachel discussed, I think there's a real need and a real opportunity at this point, given all the work that's happened on the ground, to focus on sustainability and simplicity. And I think those two concepts are really related. So to deliver whole person care through these accountable care relationships requires sustainability. And Kevin, you talked about that at the top, right? We need predictability. Payers need predictability and sustainable models to be able to deliver this type of care. I think one very concrete thing, Frank, is payment. We should continue to focus on new and simpler approaches to things like benchmarking and payment methodologies that reflect kind of the true cost of delivering care, and that over time take into account the efficiencies that are being produced, hopefully, in these programs. And then second, simplicity is a really important dimension if you want this type of care to be sustainable and scalable. We need things like common definitions. We talk a lot about quality measure, alignment, but there's a whole other layer of alignment and simplicity as well.
Yeah, so to repeat back, again, we have been on this journey for a while. Accountable care is, if nothing else, maybe job security as we try to transform slowly the delivery system over time and the payment system, like you're saying, Purva. But one of the cross-cutting themes that you guys all mentioned was kind of this idea of communication, communicating the flexibility, communicating the things that matter to patients, communicating the alignment opportunity, the data pieces. Again, and so recognizing that the work we're doing, a key part of this is communicating it to policymakers on why accountable care is important, on what that opportunity really looks like across these different things. What's maybe the advice you guys have for the folks on this webinar, or what's necessarily, again, top of mind for you when we think about trying to communicate this journey we're on, why accountable care is important, and maybe one of those kind of key tenets that we really need to impress upon people. So maybe Natalie, I start with you there, since you were talking about, again, communicating in a way that resonates with policymakers and patients.
Yeah, I think it is so important. These are such wonky concepts that unless you're in the know, it's really feels inapproachable to talk about accountable care or value-based care, whatever folks call it. We of course say patient first care because we went out and talked to people. That's the language they resonated with them the most. Again, they're at the center, and so we think about educating policymakers, many who weren't here when the ACA was passed, and many who aren't steeped in value-based care or patient-first care. They need to know how they can go back and talk to their constituents and their voters about work that they're doing in Washington and their capitals. And I said to a member of Congress the other day that they are talked to all the time about fee-for-service when they hear about how long the wait times are, how bad the experience is. And so they can use language, if they're working on stuff like accountable care, they can use language that really meets people where they are. And I would say meeting our policymakers where they are is really important. So like we said, and you can find on our website a communications guide. It has a say this, not that sort of thing on the as one of the pages, and I can do some highlights. So for instance, like I said, value-based care, it really feels subjective to people and really encourages misinterpretation that this is something that's cheap or inferior or low quality, actually. Something like talking about patient first care, quality focused care, patient first quality care, some combination of those words really is what we are seeing resonates with patients and resonating with policymakers. There's another concern when you talk to patients or policymakers out there that this is a thing that will increase the cost of care. And the idea that if you have better quality, if you have more time with your doctor, this is going to, of course, be more expensive. And so, we have language and talks about this. Actually, this approach aims to reduce the cost of care by managing people's health concerns, and which often can be expensive when they're ignored, and getting people into the right care settings with good care coordination. Patients across the country, and we hear this all the time in our research, are really scared of big changes. And so I would caution people as they're talking about accountable care of saying, this is going to revolutionize healthcare, this is going to be so totally different. You actually freak patients out and you freak policymakers out because often they feel like it's not actually going to be implemented well. Patients aren't going to be at the center, or it's going to, kind of crumble under its own weight. And so really talking about how the approach and the work that we're doing is really meant to be targeted and straightforward, and getting patients into the care that they need, we have found really resonates. And then the last thing I'll say is that, again, when we talk to policymakers and we talk to patients, they often worry that the idea that a provider would have more time with a patient actually will make it more expensive, like I said, or harder to get an appointment. We've heard that a lot. We heard that as one of the downsides that people worried about. And so instead we can talk about actually this sort of approach brings more a personalized approach, allows us to address all of a patient's needs instead of having lots of different appointments where your needs are kind of met in different ways. And so again, showing, usually we'll talk about that as realignment, we can use health policy jargon, but from the patient's point of view, a longer appointment would mean that they would have more issues addressed. And that's the sort of language that we hear from patients that they want. And it really resonates with the policymakers that we need to make sure keep this as a bipartisan kind of out in front way of transforming our healthcare system. So again, you can find a lot of this on our website at unitedstatesofcare.org in our Patient First Care Resource Hub.
Thanks, Natalie. Purva, going to you now. When we think about, again, like communication and some of the key themes we're talking about, what's necessarily your kind of advice to everyone?
Yeah, I have a couple thoughts. So I think, communication and engagement are critical, and I'm glad we're spending a few minutes talking about that today. I think they're important not only to kind of continue the momentum to start to get to that next layer of issues that we all need to work on, but they can really help, I think, inform some of the near-term transition work that not only CMS is going through, but I think that many of us are as well in the industry. So I think we've seen over the last night, I'm looking at some of the questions coming in the chat, and I see some questions on this, but we know that CMS early on has made some early tactical shifts. So for instance, the Innovation Center announced early termination of the Making Care Primary model that started last July. But we also see that the new ACO Primary Care Flex model that went live this year and that's being tested in the Permanent Shared Savings Program seems to be proceeding. So, as with any administration, we're going to see some shifts, but I take this to mean that accountable care is still an important part of the puzzle as it has been across many transitions. But we know that, for instance, the advanced primary care models, they played a large role in testing and innovating on issues that make accountable or patient first care simpler and more sustainable across payers, to go back to the themes from your first question. Again, I think of these as the next layer of issues that we all want to be working on to make this, again, more sustainable and meaningful to people. So for instance, a lot of those advanced primary care models, they allow testing of different approaches to multi-payer alignment, which again is critical for sustainability. So most recently, the center was taking a directional alignment approach that actually many folks at Duke Margolis were thought leaders on, building on, again, lessons learned from other alignment approaches in the past. These models are also, have also contributed a great deal to understanding data sharing and interoperability needs and solutions. And those needs and those opportunities aren't going to go away. And the people on the ground that are doing a lot of this work can play a really critical role, I think, in the coming months and years in communicating new ways of testing and scaling solutions to these issues and the importance of them to the people that are actually receiving care. So I think there's a lot of great work to build on and continue, and the experiences of what is working and what is still needed around alignment and data sharing and interoperability in particular will really help continue the momentum and evolution of this work, for the goals of improving care and quality and reducing healthcare costs. And I think that gathering of lessons learned and solutions can be shared not only back with CMS and policymakers, but state Medicaid programs, payers, providers, and patient groups, right? It's a whole community of folks that's on this journey.
And it is a journey. To that end, Kevin, what are your thoughts here?
Yeah, so back when I was the medical director for Meaningful Use, I had to try to explain to people why we were doing all of this technical work in interoperability. We got a lot of practice. I believe that the future is already here. It just isn't scaled. So I tend to tell a story. I tend to find a place that actually is living out what the future will be, so people can imagine it and then point to it and say, this really exists. Often I'll tell personal stories about when I've had really good care in a value-based care organization that was completely coordinated, very flexible, really centered around me. And then I'll point out, like, what are all the things that actually made that happen? The data was interoperable. The system was proactive. The waiting room was empty because they were so efficient, and they got me in right away. They supplied my equipment right in the room because there isn't a separate payment model that has to go to a separate place. So those kinds of stories tend to resonate with people. And you can often find examples all around you and hold them up, but then also hold up, here's why that works. Because the HIE in that state is so effective at moving data back and forth, you have a seamless data experience in your state. Those inspirations are an easier way to get into the technical details, I find, than starting with a policy or a technical description.
I'll just double down on what Kevin's saying. The idea, we need more stories out there about patients who feel like they're getting care differently. They notice that care is different because if they are in a model or some other different way of delivering care. We need providers that are out there talking about it and in tangible ways. The storytelling aspect of it, I think is critical, and I think is kind of missing from the field right now.
Yeah, and maybe keeping on this story theme and a coherent kind of message. Natalie, returning to your metaphor of like a tray that we kind of have at a cafeteria of healthcare, so to say, and you're just going around, and to some extent, patients feel like you're just kind of slopping on different components of healthcare, whereas ideally what we want is kind of an aligned menu or a synergistic menu of a full plate of, got your fruits, your veggies, but also like there's a coherent theme here and it all tastes good because it works together. It's pleasing to the palate because there was some thought behind it and everything, like you're saying, Kevin, is working succinctly. And so with that idea of kind of like coordination and alignment, returning to kind of what Kevin was saying early on about alignment and Purva, Natalie, what you guys were saying about alignment, would love to hear from you guys. What necessarily are those near-term opportunities to continue to progress and promote alignment? Recognizing again, like you can't, redesign a cafeteria overnight. There's bricks and mortar that would have to come down, but there are things we can do, like again, to the menu perhaps of healthcare, things we can do to data or to make the system a little bit more efficient so there's not so many people in the waiting room. But around this key theme of alignment, making sure that, again, like the menu, it all kind of works together and stakeholders are all kind of talking and coordinating. So would love to hear from you guys, and maybe Kevin, we start with you about what are those near-term opportunities to really promote and progress alignment?
Boy, it's a big one, and it's a tough one. But part of my time at HHS, I got to spend with the state innovation models, going to numerous states, helping them. And again, I'll start at a sort of technical place. The states weren't set up for alignment. They have multiple funding streams coming to different parts of their state. They have redundant IT systems that don't talk to each other. It was really hard for the states to envision a future that they, through their Medicaid program, could have an aligned approach, because the health department didn't talk to the Department of Human Services that ran Medicaid, and the people are in and out of corrections, and there's no collaboration connection there. And some of that has to do with how the federal government has created those funding streams and created the policies that you can't actually reconcile at the state level. So there are creative ways around it, but it would be lovely to be able to create a model where we would articulate here is what we think some best practices are for that technical alignment, for your systems to talk to each other. In health IT, we talk about a master person index. That's a healthcare organization. We know who you are. The states had multiple of these, and they couldn't actually share the simplest things like patient IDs across the state systems because they didn't have a single master person index. So I think there are some technical approaches that then unleash a whole lot of other opportunities. There's a kind of a commercial approach that mass simplification leads to mass customization. If you think of Amazon, they have a single way that you engage with tens of thousands of different vendors. It used to be you'd have to go to each of those vendors separately, right? They standardized across Amazon the way you interact, and now you can customize all sorts of stuff at all sorts of places through one portal. The question is, how do we build those same kinds of systems with that kind of standardization so that it's much more straightforward to have these systems that talk to each other, that connect, that collaborate, that share?
Okay. Natalie, maybe I turn to you, since you gave us this metaphor in terms of the alignment and the cafeteria. Necessarily, what's that near-term opportunity for alignment there?
Yeah, I love that you're continuing to use the analogy. I don't know if I'll be as so eloquent to be able to continue it the way you did. I think as we think about near term and building towards long term, as we call it, patient first care, it really has to be that we have patients and their perspectives in there while we design models, while we fix them as we go. My father is in the hospital right now from a fall due to his Parkinson's. I think this is the 6th hospital stay he's had in less than a year over his 10-year diagnosis. I can tell you that there is nobody that knows, at least in Maryland, how to help a Parkinson's patient through a broken healthcare system better than my stepmother. She should be at the table as we design a model of what it would look like to build a patient-first care model for people with Parkinson's. That's just an example, but I think all of you can think of somebody in your life who, because they had to navigate a healthcare system, knows it probably better than anybody else. They should be there while we're building these models. I think we need to then really incentivize and really protect those providers who are able to improve health outcomes and deliver higher quality care, and making sure they're rewarding those providers and as they are, and this means measuring, but as they have better positive health outcomes, better patient experience, and other metrics. And then somehow we need to really figure out how to bring all of the essential elements of whole person care into these models. For us, and Purva mentioned this means recognizing primary care as one of the foundations of these models, and how to effectively, help people stay healthy, be as healthy as they can, and make it through the healthcare system. And then that care coordination is so important. And lastly, we would say, making sure that we promote accountability within these models to make sure that these providers are delivering the high quality care. And that, to me, it would be such an exciting project of establishing more patient-centric quality metrics and robust reporting requirements. My stepmom should know who she should go to, which not only Parkinson's provider, neurological provider, the hospital ER that she should go to when my dad falls, the outpatient rehab, the acute rehab. We should know in a patient-centric way the best way to get ourselves and loved ones care. And I think that really is the promise. Again, we don't want to just call it first care if it's not, but I think these are steps that can help us build towards that high school cafeteria analogy of better patient care.
Purva, what's top of mind for you?
Yeah, there's a lot to choose from on the opportunity front, in a good way. Natalie references too, but one of the thoughts I was having was that, a lot of work is, when we think about accountable care in this movement, a lot has been done to try to strengthen primary care. And that's really the foundation of the accountable care work and of a high performing health system. So we know that we've got to get, folks in the door in a longitudinal primary care based relationship for most of them. But there's a lot about, where we go next to better support people with often complex needs. I mean, Natalie's describing her father, for instance, and the frontline clinicians that are, working with patients and families day to day. I think I mentioned this at the top, but, I can spend a minute or two talking about specialty care as a near-term opportunity. It's a really important part of accountable care. When we see accountable care come to fruition, we should see people's specialty needs also being met and coordinated when they're receiving care under this framework. I think there's some really impactful near-term opportunities to continue, some of the early testing and progress in this area around how do we bring primary and specialty care together? How do we get the two coordinating better? And how do we move towards integration in the long run? And some areas that I think we can really lean into. For instance, can CMS and other payers apply or even evolve some of the shadow bundle data that's been released to the ACOs to help ACOs support specialty care management? Could the specialty performance profiling work that some of you might be familiar with that started under Making Care Primary, where primary care providers are actually getting profiles of the specialists that are in their market and looking at the cost and quality of the care that they're providing. Can that be tested or applied in other models, in other accountable care programs, or with other payers? That's really important information. Try to get folks to high performing providers. And then I think there's also the mandatory team model, the bundled payment model that kicks off in 2026, which will also engage more specialists. And that model do more, to engage more specialists either through more episodes or really leaning into how a model like that creates connections back to primary care and accountable care in particular. So I think those are some near-term opportunities. And then obviously there's the whole, all the ACO programs and work. And we know that the ACO REACH model is scheduled to end, for instance, in 2026. And as the agency, as CMS considers a future model or improvements to the shared savings program, maybe both, that's another opportunity, I think, to really test ways to engage more specialists, to support longitudinal management of primary and specialty conditions, and to be thinking about the ways that we can get and better support primary and specialty care coordinating together. I think one of the other things that was being tested in the Making Care Primary model are ambulatory care, like co-management codes, right? Those are the actual building blocks and linkages that you can test and try out to see, does that give folks some aligned financial incentive to be able to coordinate and better care for patients. So those are the kinds of things those are some of the seeds that have been planted that I think we can take a look at and see, are these things that other payers can pick up? Are these things that can be tested in the ACO programs or in the permanent shared savings program? And then the last near-term opportunity, I think, is one that you all at Duke and Margolis have been talking about for a long time, and always reminded me of when I was at the Innovation Center. But it's that continued coordination across the agency, right? The Innovation Center, the Center for Medicare, the Center for Medicaid and CHIP Services. I see Kevin nodding too from his time there. And I think there has been some really good coordination and work over the last several years in support of accountable care. So it's that coordinated policy making that creates permanent change and the predictability that I think everyone needs and is looking for. And so, in the near term, really hope that work continues both on the ACO side and some of the new work that was happening in the Medicare physician fee schedule as well around the advanced primary care management codes, for instance. Like, those were really great collaborations across CMS to try to move towards a shared vision and then collaborative policymaking to achieve that vision.
Yeah, thank you guys for that. I think, kind of picking up what Nimrata said early on, there is a plurality of solutions out there near term that we can continue to build on. And so it's helpful to kind of, again, as you guys did, keep it practical, show kind of the bright spots that are happening, and where there's an opportunity to continue to build on those in the near term. So I want to go back to something Kevin was saying, and we all agree kind of with that. Describing healthcare is really challenging, and sometimes we have to do it through stories. And what Kevin was talking about was describing when it works well, what success was in that situation, that there was no wait time in the waiting room. They could address his needs immediately. The payment system was seamless. And so getting the equipment was there, the tests were there, the providers were there. And so again, describing not just a story, but what success looks like often makes us a lot more tangible for people. And so I think where I would like to close out and give you guys a few minutes is really just an open-ended kind of discussion, remarks from you guys as we close out today. What does success look like? I think recognizing kind of one of the key theses from our health affairs piece was accountable care is at an inflection point. And when we started this journey decades ago, the idea was we just need to get people in models. We just need to get people into these alternative payment models. We need to promote value-based care. Now we're recognizing, well, value-based care is not really necessarily resonating as a word. Getting people in models isn't necessarily enough. And so would love to hear from you guys, recognizing we need to re-examine our key motivations here for why join accountable care. What does success look like? And maybe we start with you, Natalie. What does success look like in your mind for accountable care going into the future?
I think where we stop doing healthcare at people and bring them into the fold. They're not sent a letter that you're now assigned to this ACO, but they understand first that's language that they understand, but also they are part of that decision. Taking a step back, I already said, I think success would look like we have people involved in every step of the way of what they should look like, how the patient experience should be, what the quality measures are, how physicians want this to work. I think we also have to like redefine what our word success means. At one point perhaps, or for some, it means saving money, period. And I don't think that's going to get us where we want to go. It's not going to bring patients into the fold. It's not going to deliver on the promise that we should be of reimagining and delivering healthcare differently. And then I think in the micro sense, like I said, there's a success of what does that mean to patients? Are we thinking about quality measures in a new way? What does success mean to physicians? I mean, we should go out and ask them that, and then figure out if there's a way to measure or move towards their definition of success. And I think very concretely, as we think about CMMI over its lifespan, it has been extremely engaged with stakeholders. It has been transparent as possible into how it's thinking about models, where it's going, what is CMMI centering. I think even the notice that went out last week, that was a step into transparency on how the new administration is thinking about CMMI and the models. And so I would just encourage this administration and all the administrations to come to make sure that it stays a bipartisan issue, that it's there to really focus on bringing, better care to patients with better outcomes, and kind of rethinking the delivery system and being transparent and engaging with external stakeholders. It's been a strength of the department and of CMS, and I encourage them for that to continue to be the future of how we build.
Purva, what about you? What's success look like, you think?
I'm going to start by stealing Kevin's line that the future is here, but it hasn't been scaled yet.
It's
So,
such a good line,
yeah,
Kevin.
no, it's such a good
So
line.
good.
Sorry, Kevin, I hope you didn't trademark it because we're all going to use it now. But I think success looks like scaling. And more people receiving accountable care. So it sounds silly, but that number that we hit over 50% traditional Medicare. Other sectors, most recently through the LAN, are tracking some of those numbers, right? There are some common definitions now around what accountable care is across, among different payers, where we're tracking what those numbers look like. But I think scaling that, right, so that more people are receiving care that is coordinated and team-based and more efficient for the health system, to me, is success, and gradual, and continued and steady progress, I think, is really important. But getting to that future state, to build a little bit on what Natalie said, is going to require communication and engagement. It's going to require patient groups, providers, and payers to share with policymakers and each other what is and isn't working on the ground, especially for what I talked about as that kind of next layer of issues around accountable care to get it to actually work, to get more people in it. We've got to get deeper on alignment and specialty engagement and data sharing and some of the other things that we covered. And I think success means that we're working within this goal and this framework, but we're testing ideas more rapidly, and we're bringing new solutions to policymakers and to others that are advancing accountable care. So we're building kind of a system of kind of continual learning and improvement here.
Kevin?
Yeah, so some of you know that I'm a big fan of the lean total production system approach and think about waste. And when I was at a health system as an executive, I considered anytime we did care coordination, there was waste. That meant that something about our system was broken, that somebody with expertise actually had to shuffle a patient around. In the ideal system, that isn't the case. The ideal system, you get to the right place the first time. Things are self-serve and easy to use. They are what you want when you want it, as opposed to it being, you got to figure all this out. And that is not just waste for the patients and their caregivers, it's waste for the providers, it's waste for the health systems to have to hire all these people to patch all this stuff together. So when I work with really mature value-based care systems, they have eliminated a bunch of that kind of waste in their system. They're much more user-friendly, they're much more integrated, they're much more connected, they're much more person-centered. And so that's the future that I see. I think one of the core challenges is that has caused consolidation, because it's easier to do that within a single organization. So that's why interoperability is so important. If we're going to have a free market where this also works, we actually need our systems to be able to connect and the data to move back and forward like Amazon does with all of its vendors. That's the kind of way that interoperability helps make this happen in a system that we don't have just big integrated organizations.
Thanks, Kevin. And thank you, Natalie, Purva, Kevin, for joining us today, for giving your insights and perspective, for spending time with us. Thank you, Rachel, for teeing up such a good conversation with the slides. Rob and Namrata for providing the guardrails again, and then West Health for the support for this kind of work. I think just to crystallize a few things I heard everyone say, Rob, Namrata, Rachel, as well as our panel, again, returning to those key themes. A lot of this goes back to simplicity and about making sure it's easier to get into models. And we talked a little bit about alignment and what that means from a payer perspective and a provider perspective, as well as simplicity, like the outcomes that matter for patients. And that sometimes it's really challenging to understand not just your performance within a model, but how to get into a model. We heard a lot about transparency too. We heard everything from, it's great that some of the steps the administration has taken to improve transparency in terms of the announcements, but we also talked a little bit about how data exchange could help improve transparency. Purva was talking about, some of the shadow bundle information that has been published now on GitHub, and the ability to potentially leverage that to understand performance and what is meaningful for patients and the providers participating in models. Explainability was another big theme we talked about today, communicating accountable care in a meaningful way to clinicians on the ground, but also to the patients. We know that they see healthcare, again, continuing on this theme, as kind of like this tray where often we're slopping down different things. And maybe if we had, a better system, better words to explain what they were eating and why it's good for them, the next iteration of accountable care would be a little bit more transparent. Flexibility. I really liked, Kevin, how you were kind of explaining what success looked like in your example of receiving your own personal health care and how everything was lining up. And that's because of things that, again, like alternative payment models allow clinicians to do, allow payers to do as well. Again, allowing these systems to work more seamlessly together, but all of the different parts, the components of the system, helping one another along. And then, Purva, you were talking a lot about sustainability, making sure that across state, regional, as well as federal efforts, that as all these pieces move together, that each individual piece feels supported in what it's doing. The data is being fed back to the provider who can make real-time decisions. And the kind of what Kevin was saying about the system being broken when there is kind of the care coordination going on, that we have a system that recognizes necessarily what's not working, but we're scaling in a rapid fashion what is working. I'm definitely going to steal that line too from Kevin. So thank you everyone again for participating today. Really appreciate our panel, appreciate Rob, Namrata, Wes, Rachel, and all of you for joining us today. Yes, we'll post slides, we'll post a recording in the near term, probably in the coming days. But again, thank you guys for everyone for your time, and looking forward to the next quarterly webinar with West Health.